Question 1. The evaluation methodology shows a 58-year-old male complaining of crushing substernal chest pain radiating to his left arm, accompanied by shortness of breath and diaphoresis. His vital signs are pulse 98 bpm, respirations 20/min, blood pressure 130/80 mmHg, and SpO2 96% on room air. He has a history of hypertension and GERD. Based on NREMT EMT certification exam guidelines, which of the following actions is the most appropriate initial management for this patient? Option A. Focus on managing the shortness of breath with oxygen and transport without administering aspirin or nitroglycerin due to his history of GERD. Option B. Administer aspirin 324 mg chewed and assist with nitroglycerin 0.4 mg sublingually if blood pressure remains stable and no contraindications are present. Option C. Administer nitroglycerin 0.4 mg sublingually immediately and then administer aspirin 324 mg chewed. Option D. Administer aspirin 324 mg chewed and advise the patient to rest while awaiting further medical evaluation. Correct answer is B. Administer aspirin 324 mg chewed and assist with nitroglycerin 0.4 mg sublingually if blood pressure remains stable and no contraindications are present. Explanation. This scenario presents a common but critical challenge in pre-hospital care, differentiating between various presentations of chest pain and initiating appropriate, timely interventions within the NREMT EMT scope of practice. The professional challenge lies in the potential for rapid deterioration of the patient's condition and the need to act decisively based on limited information and established protocols. Misinterpretation can lead to delayed or incorrect treatment, with potentially life-threatening consequences. The correct approach represents best professional practice by adhering strictly to NREMT guidelines for suspected acute coronary syndrome, ACS. This includes administering aspirin to inhibit platelet aggregation and nitroglycerin to improve coronary blood flow and reduce myocardial oxygen demand, provided contraindications are absent and the patient's condition warrants it. These interventions are evidence-based and are within the EMT's scope of practice when indicated for suspected ACS, aiming to mitigate myocardial damage. This aligns with NREMT emphasis on standardized, evidence-based patient care. An incorrect approach of withholding aspirin due to a history of gastrointestinal upset, without further assessment for contraindications or consideration of alternative administration routes if available within protocol, fails to address the immediate life threat of ACS. This could be a regulatory failure if protocols allow for aspirin administration in such cases with appropriate precautions, or an ethical failure for not acting in the patient's best interest when a potentially life-saving intervention is indicated. Another incorrect approach of administering nitroglycerin without assessing blood pressure first is a significant regulatory and ethical failure. Nitroglycerin is a vasodilator and can cause profound hypotension, which would be detrimental to a patient experiencing ACS and could lead to shock or cardiac arrest. This directly violates established protocols designed to ensure patient safety. Finally, an incorrect approach of focusing solely on non-cardiac causes without a thorough ACS assessment, despite classic symptoms, represents a failure to recognize and manage a time-sensitive emergency, potentially delaying critical treatment and violating the duty of care. Professional reasoning in such situations requires a systematic approach, rapid patient assessment, identification of signs and symptoms suggestive of ACS, consideration of patient history and contraindications, adherence to established NREMT protocols for ACS management, and clear communication with medical direction or receiving facility. The EMT must prioritize interventions that address the most immediate life threats while remaining within their authorized scope of practice. Question 2. Quality control measures reveal a pattern of incomplete cardiac assessment in simulated scenarios involving patients presenting with epigastric discomfort and nausea. In one simulation, the EMT focused exclusively on gastrointestinal symptoms, neglecting a thorough cardiac evaluation. Which of the following approaches best reflects the NREMT required standard for assessing a patient with potential cardiac distress, even when symptoms are atypical? Option A. Immediately administer aspirin and nitroglycerin based on the presence of nausea and epigastric discomfort. Option B. Conduct a comprehensive sample history, assess vital signs including pulse rate and rhythm, auscultate heart sounds, and inquire about chest pain characteristics and associated cardiac symptoms. Option C. Focus solely on the patient's reported gastrointestinal symptoms and provide comfort measures. Option D. Administer an antacid and reassess gastrointestinal symptoms, assuming the discomfort is purely digestive. The correct answer is B. Conduct a comprehensive sample history, assess vital signs including pulse rate and rhythm, auscultate heart sounds, and inquire about chest pain characteristics and associated cardiac symptoms. Explanation. Scenario analysis. This scenario presents a common but critical challenge in emergency medical services. A patient exhibiting symptoms suggestive of cardiac distress, but with a history that might point to other causes. The EMT must navigate the urgency of a potential cardiac event, while avoiding premature conclusions that could lead to delayed or inappropriate treatment. The challenge lies in the differential diagnosis and the need for a systematic, evidence-based approach to patient assessment, adhering strictly to NREMT standards. Correct approach analysis. The correct approach prioritizes a comprehensive cardiac assessment, integrating patient history, vital signs, and direct physical examination of the cardiovascular system. This aligns with NREMT emphasis on systematic patient assessment protocols. Obtaining a detailed sample history, specifically inquiring about chest pain characteristics, onset, provocation, quality, radiation, severity, time, associated symptoms, dyspnea, nausea, diaphoresis, and relevant cardiac history, previous MI, angina, hypertension, diabetes is foundational. Simultaneously, assessing vital signs including pulse rate and rhythm, blood pressure and respiratory rate provides objective data. Auscultating heart sounds for rate, rhythm, and presence of abnormal sounds, murmurs, gallops, further refines the assessment. Recognizing signs and symptoms of cardiac distress, such as pallor, diaphoresis, anxiety, and altered mental status, is crucial for identifying potential life threats. This integrated approach ensures that all relevant data points are considered, leading to a more accurate and timely diagnosis and treatment plan, consistent with NREMT focus on patient safety and effective care. Incorrect approaches analysis. Focusing solely on the patient's reported gastrointestinal symptoms without a thorough cardiac assessment is a critical failure. This neglects the potential for referred pain or atypical presentations of cardiac ischemia, which can manifest as epigastric discomfort or nausea. Such an approach violates NREMT mandate for a comprehensive patient assessment, potentially delaying life-saving cardiac interventions. Prioritizing the administration of a medication based on a single symptom without completing the full assessment is also a significant regulatory and ethical failure. NREMT protocols emphasize a systematic approach, and administering medication without a complete understanding of the patient's condition can lead to adverse effects or mask critical findings. This bypasses essential diagnostic steps and could result in inappropriate treatment. Ignoring the patient's vital signs and proceeding directly to a focused history on a non-cardiac complaint is another unacceptable approach. Vital signs are objective indicators of physiological status and can provide crucial clues to the severity of a patient's condition, including potential cardiac compromise. Failing to obtain and interpret vital signs is a direct contravention of standard EMS assessment practices mandated by NREMT. Professional reasoning. Professionals should employ a systematic approach to patient assessment, beginning with scene safety and general impression, followed by a primary assessment, APDE. For a patient with potential cardiac distress, this transitions into a focused history and physical examination, prioritizing cardiac-specific questions and assessments. The sample history, OPCAS mnemonic for pain assessment, and vital signs are essential components. Auscultation of heart sounds and observation for signs of poor perfusion are critical. This structured process, guided by NREMT protocols and clinical judgment, allows for the identification of life-threatening conditions and the initiation of appropriate interventions while considering differential diagnosis. Question 3. Research into the management of a 72-year-old male patient experiencing sudden onset of severe shortness of breath, audible crackles in both lung fields, and significant bilateral lower extremity edema, who has a known history of hypertension and coronary artery disease. The patient is conscious and alert, but appears anxious and is using accessory muscles to breathe. Which of the following immediate management strategies within the NREMT EMT scope of practice is most appropriate for this patient? Option A. Initiate immediate transport without further intervention, as the patient's condition is too severe for EMT-level management. Option B. Focus solely on obtaining a detailed medical history and vital signs, delaying oxygen administration until advanced personnel arrive. Option C. Administer high-flow oxygen via non-rebreather mask. Position the patient in a semi-Fowler's position and prepare for assisted ventilation if respiratory status declines. Option D. Administer a prescribed bronchodilator from the patient's home medication, as this presentation is likely an asthma exacerbation. The correct answer is C. Administer high-flow oxygen via non-rebreather mask, position the patient in a semi-Fowler's position, and prepare for assisted ventilation if respiratory status declines. Explanation. This scenario presents a common but potentially critical challenge for an EMT, differentiating between the signs and symptoms of acute exacerbation of congestive heart failure, CHF, and other respiratory distress etiologies, particularly in a patient with a history of chronic conditions. The professional challenge lies in rapid, accurate assessment and initiation of appropriate interventions within the scope of practice, as delayed or incorrect management can lead to rapid patient deterioration and adverse outcomes. The patient's presentation of shortness of breath, crackles in the lungs, and peripheral edema are classic indicators of CHF exacerbation, but other conditions like pneumonia or pulmonary embolism could present similarly. The correct approach prioritizes immediate, evidence-based interventions aligned with NREMT EMT scope of practice for CHF. This includes positioning the patient for comfort and optimal breathing, e.g., sitting up, administering high-flow oxygen to improve oxygenation, and potentially assisting with positive pressure ventilation if indicated by respiratory distress and patient condition. These actions directly address the underlying pathophysiology of CHF exacerbation, which involves fluid backup in the lungs and systemic circulation, leading to impaired gas exchange and increased work of breathing. Adherence to these protocols ensures patient safety and maximizes the chances of stabilization before advanced care arrives, aligning with NREMT guidelines for patient assessment and management of respiratory emergencies. An incorrect approach would involve delaying oxygen administration, failing to position the patient appropriately, or attempting interventions outside the EMT scope of practice. For instance, administering medications without a physician's order or advanced provider direction would be a significant regulatory and ethical failure, violating the principle of practicing within one's certified level and potentially harming the patient. Another incorrect approach would be to dismiss the symptoms as solely due to the patient's known chronic lung disease without considering the possibility of acute CHF exacerbation, leading to a failure to initiate appropriate CHF management. This represents a failure in differential diagnosis and a deviation from best practice in patient assessment, potentially resulting in delayed or inadequate treatment. Professional decision-making in such situations requires a systematic approach. First, a rapid primary assessment to identify life threats. Second, a focused secondary assessment to gather relevant history and perform a physical exam, specifically looking for signs and symptoms of CHF. Third, consideration of differential diagnoses based on the findings. And finally, the application of appropriate evidence-based interventions within the EMT scope of practice, all while maintaining clear communication with the patient and dispatch. Question 4. Compliance review shows a need to reinforce understanding of the heart's electrical system, which statement accurately describes the normal sequence of electrical impulse generation and conduction in the heart, initiating a heartbeat. Option A. The impulse originates in the sinoatrial SAW node, travels to the atrioventricular AV node, then to the bundle of His bundle branches and Purkinje fibers. Option B. The impulse originates in the atrioventricular AV node, travels to the sinoatrial SAW node, then to the bundle of His bundle branches and Purkinje fibers. Option C. The impulse originates in the bundle of His, travels to the sinoatrial SAW node, then to the atrioventricular AV node bundle branches and Purkinje fibers. Option D. The impulse originates in the Purkinje fibers, spreads to the bundle branches, then to the bundle of His, and finally to the atrioventricular AV node. The correct answer is A. The impulse originates in the sinoatrial SAW node, travels to the atrioventricular AV node, then to the bundle of His bundle branches and Purkinje fibers. Explanation. Scenario analysis. This scenario presents a challenge in applying foundational knowledge of cardiovascular anatomy and physiology to a clinical situation. The EMT must differentiate between the normal electrical pathway of the heart and a pathological deviation, understanding how disruptions in this pathway can manifest clinically. This requires more than rote memorization. It demands an understanding of the functional implications of structural and electrical components. Correct approach analysis. The correct approach demonstrates an understanding of the cardiac conduction system's normal function. It correctly identifies the sinoatrial SA node as the primary pacemaker and the atrioventricular AV node's role in delaying impulse transmission to allow for atrial contraction before ventricular contraction. This aligns with NREMT EMT certification exam expectations, which assess the ability to apply anatomical and physiological principles to patient assessment and care. Understanding this pathway is critical for interpreting cardiac rhythms and recognizing potential abnormalities. Incorrect approaches analysis. One incorrect approach might focus solely on the physical structure of the heart chambers without acknowledging the electrical system's role in coordinated contraction. This fails to address the underlying mechanism of cardiac function relevant to the question. Another incorrect approach could incorrectly assign the primary pacemaker function to a different part of the conduction system, such as the Purkinje fibers. This demonstrates a fundamental misunderstanding of the cardiac electrical hierarchy. A third incorrect approach might confuse the electrical conduction pathway with the circulatory pathway of blood, focusing on arteries and veins rather than the specialized cells responsible for generating and conducting electrical impulses. This shows a lack of understanding of the distinct systems within the cardiovascular framework. Professional reasoning. EMTs must approach patient care by first establishing a baseline understanding of normal physiological processes. When presented with a clinical scenario or a question about a physiological concept, the professional decision-making process involves recalling and applying the established knowledge base. This includes understanding the sequence of events in the cardiac conduction system, the roles of different components, and how these contribute to effective cardiac output. This systematic recall and application are essential for accurate assessment and appropriate intervention, as mandated by NREMT standards. Question 5. Governance review demonstrates that an EMT is assessing a 68-year-old male complaining of sudden onset shortness of breath. The patient is conscious and alert, but appears anxious and is using accessory muscles to breathe. His skin is cool and clammy, and his respiratory rate is 28 breaths per minute with shallow tidal volumes. His pulse oximetry reading is 88% on room air. Which of the following represents the most appropriate initial management approach for this patient, adhering strictly to NREMT EMT certification standards? Option A. Immediately begin a detailed sample history to gather information about the onset of symptoms. Option B. Attempt to insert an oropharyngeal airway and suction the airway if secretions are present. Option C. Administer aspirin 324 mg chewed by the patient to address potential cardiac causes. Option D. Administer high-flow oxygen via a non-rebreather mask and ensure a patent airway. The correct answer is D. Administer high-flow oxygen via a non-rebreather mask and ensure a patent airway. Explanation. Scenario analysis. This scenario presents a common challenge in pre-hospital care where a patient exhibits signs of respiratory distress, but the underlying cause is not immediately obvious. The EMT must quickly assess the patient's airway, breathing, and circulation, and then apply appropriate interventions based on their understanding of respiratory physiology and NREMT scope of practice. The challenge lies in differentiating between conditions that require basic airway management and oxygenation versus those that might necessitate advanced airway interventions or specific pharmacological treatments, all while adhering to established protocols and patient safety. Correct approach analysis. The correct approach prioritizes the immediate ABCs, airway, breathing, circulation, and the administration of high-flow oxygen. This aligns with NREMT EMT certification standards, which emphasize foundational life support skills. Ensuring a patent airway, assessing the quality of respirations, and providing supplemental oxygen are critical first steps in managing any patient with suspected respiratory compromise. This approach is directly supported by NREMT guidelines that stress the importance of oxygenation and ventilation in maintaining cellular function and preventing further deterioration. It is the most appropriate initial intervention for a broad range of respiratory emergencies. Incorrect approaches analysis. One incorrect approach involves delaying oxygen administration to focus solely on obtaining a detailed patient history. While history is important in a patient exhibiting signs of respiratory distress, immediate oxygenation takes precedence over extensive questioning. This failure to prioritize life-saving interventions violates the NREMT emphasis on rapid assessment and management of life threats. Another incorrect approach is to immediately attempt advanced airway insertion without first exhausting basic airway maneuvers and oxygenation. The EMT scope of practice is focused on basic life support. Attempting advanced procedures beyond their certification level or without clear indications and proper training constitutes a significant regulatory and ethical failure, potentially causing harm to the patient and exceeding the EMT's legal authority. A third incorrect approach is to administer a medication without a clear medical direction or a specific protocol for the patient's presentation. EMTs are trained to administer certain medications under specific circumstances and often with medical direction. Administering medication without proper authorization or indication is a violation of NREMT protocols and can lead to adverse patient outcomes. Professional reasoning. When faced with a patient in respiratory distress, the EMT should follow a systematic approach. 1. Assess the scene for safety. 2. Perform a rapid primary assessment focusing on airway breathing and circulation. 3. Ensure a patent airway using appropriate maneuvers. 4. Assess the rate, rhythm, and quality of respirations. 5. Administer high-flow oxygen via the appropriate device, e.g., non-rebreather mask, if indicated by the patient's condition and oxygen saturation. 6. Obtain a focused history and perform a secondary assessment while continuously monitoring the patient's condition. 7. Follow local protocols and medical direction for further interventions. Question 6. Which approach would be most appropriate for an EMT to manage a patient who is unresponsive, breathing shallowly at 8 breaths per minute, and has a pulse of 110 beats per minute, following NREMT guidelines for ventilation? Option A. Apply a nasopharyngeal airway and ventilate with a BVM delivering 100% oxygen at a rate of 10-12 breaths per minute. Option B. Administer high-flow oxygen via a non-rebreather mask and monitor the patient's respiratory rate. Option C. Apply a nasopharyngeal airway and ventilate with a bag valve mask, BVM, at a rate of 10-12 breaths per minute with room air. Option D. Perform endotracheal intubation and ventilate with a BVM delivering 100% oxygen at a rate of 10-12 breaths per minute. The correct answer is C. Apply a nasopharyngeal airway and ventilate with a bag valve mask, BVM, at a rate of 10-12 breaths per minute with room air. Explanation. This scenario presents a common challenge in pre-hospital care, managing a patient with altered mental status and signs of respiratory distress, requiring effective ventilation. The professional challenge lies in accurately assessing the patient's needs and applying the most appropriate ventilation technique while adhering to NREMT standards and best practices for patient safety and oxygenation. The EMT must balance the urgency of the situation with the need for precise, evidence-based interventions. The correct approach represents best professional practice because it prioritizes a definitive airway and controlled ventilation when indicated by patient condition and available equipment. For a patient exhibiting signs of inadequate breathing, such as altered mental status and labored respirations, the use of a supraglottic airway or endotracheal intubation, followed by BVM ventilation with supplemental oxygen, is the most effective method to ensure adequate oxygenation and ventilation. This aligns with NREMT guidelines that emphasize securing the airway and providing ventilatory support to prevent hypoxia and hypercarbia, thereby improving patient outcomes. The controlled delivery of breaths with a BVM attached to a definitive airway allows for consistent tidal volume and respiratory rate, which is crucial for this patient population. An incorrect approach would be to solely rely on a simple airway adjunct like a nasopharyngeal airway and attempt BVM ventilation without a definitive airway. While a nasopharyngeal airway can help maintain an open airway, it does not guarantee a patent airway in a patient with significantly altered mental status or potential airway collapse. This could lead to inadequate ventilation and continued hypoxemia, failing to meet the standard of care. Another incorrect approach would be to administer high-flow oxygen via a non-rebreather mask without addressing the underlying inadequate ventilation. While oxygen is important, it does not provide the necessary ventilatory support for a patient whose breathing is insufficient. This fails to address the primary problem of inadequate gas exchange. Administering only supplemental oxygen without adequate ventilation is a critical failure in patient management. Professional decision-making in such situations requires a systematic approach. First, assess the patient's airway, breathing, and circulation, ABCs. If breathing is inadequate, rate, depth, or tidal volume, consider interventions to improve ventilation. This includes manual maneuvers, airway adjuncts, and ultimately, definitive airway management if the patient's condition warrants and resources allow. Always consider the patient's level of consciousness and ability to protect their own airway. If the patient is unable to maintain an adequate airway or ventilation, advanced airway management and mechanical ventilation, if available and within scope, become paramount. Continuous reassessment of the patient's response to interventions is critical. Question 7. The review process indicates that an unresponsive adult patient with a suspected head injury is exhibiting noisy respirations and appears to have a partially obstructed airway. The patient's mechanism of injury suggests a potential for cervical spine trauma. Which of the following actions is the most appropriate initial step to manage this patient's airway? Option A. Perform a head tilt/chin lift maneuver to open the airway. Option B. Insert a nasopharyngeal airway. Option C. Insert an oropharyngeal airway. Option D. Perform a jaw thrust maneuver to open the airway. Correct answer is D. Perform a jaw thrust maneuver to open the airway. Explanation. Scenario analysis. This scenario presents a common challenge in pre-hospital care where a patient's airway is compromised due to altered mental status and potential trauma. The EMT must quickly assess the situation and select the most appropriate airway management technique, balancing the need for airway patency with the risk of exacerbating potential injuries. The challenge lies in recognizing the subtle signs of airway compromise and applying the correct maneuver without causing further harm, adhering strictly to NREMT guidelines. Correct approach analysis. The correct approach involves a rapid assessment of the airway and the patient's level of consciousness. Given the patient's altered mental status and potential for spinal injury, the jaw thrust maneuver is the preferred method for opening the airway. This technique is specifically indicated when a cervical spine injury is suspected or cannot be ruled out, as it lifts the mandible forward without significantly moving the head and neck. This aligns with NREMT protocols emphasizing patient safety and minimizing movement in suspected trauma. Maintaining airway patency is paramount, and the jaw thrust maneuver achieves this while respecting potential spinal precautions. Incorrect approaches analysis. Using the head tilt/chin lift maneuver without first ruling out a cervical spine injury is a significant regulatory and ethical failure. This maneuver, while effective for opening the airway in non-trauma patients, can cause dangerous movement of the cervical spine, potentially leading to paralysis or further injury in a trauma patient. This directly violates the principle of do no harm and NREMT guidelines for trauma patient management. Attempting to insert an oropharyngeal airway, OPA, without first ensuring a patent airway through manual maneuvers is also incorrect. The OPA is an adjunct to maintain airway patency, not a primary method for opening a compromised airway. If the airway is not adequately opened, the OPA may not be effective and could even obstruct the airway further or cause gagging and vomiting, especially in a patient with an altered mental status. Inserting a nasopharyngeal airway, NPA, without first attempting manual airway opening maneuvers is also inappropriate. While the NPA is useful when the OPA cannot be inserted or in patients with a gag reflex, it is still an adjunct. The primary responsibility is to establish a patent airway using the most appropriate manual technique based on the patient's condition. Furthermore, the NPA is contraindicated in cases of significant facial trauma, which should be considered in a patient with altered mental status and potential mechanism of injury. Professional reasoning. In any pre-hospital scenario involving an altered mental status or potential trauma, the EMT's decision-making process must begin with a rapid primary assessment, focusing on airway, breathing, and circulation, ABC. If the airway is compromised, the EMT must determine the most appropriate method to open it. The presence of suspected or potential cervical spine injury dictates the use of the jaw thrust maneuver. If no spinal injury is suspected, the head tilt/chin lift is appropriate. Once the airway is open, the EMT assesses the need for adjuncts like OPAs or NPAs based on the patient's gag reflex and the effectiveness of the manual maneuver. This systematic approach, prioritizing patient safety and adhering to established protocols, is crucial for effective and ethical patient care. Question 8. The analysis reveals that an EMT is presented with a patient experiencing acute shortness of breath, chest tightness, and wheezing. The patient has a history of asthma. However, the EMT also notes a sudden onset of shortness of breath following a period of immobility, and the patient reports sharp, localized chest pain that worsens with inspiration. Considering the NREMT regulatory framework for respiratory emergencies, which of the following assessment and management priorities is most appropriate for the EMT to pursue initially? Option A. Administer supplemental oxygen and a prescribed bronchodilator, as the patient has a history of asthma and is exhibiting wheezing. Option B. Focus on managing hyperventilation syndrome by encouraging slow, deep breathing and reassurance, as the patient is anxious due to their shortness of breath. Option C. Immediately suspect and assess for a pneumothorax or pulmonary embolism due to the sudden onset, sharp pleuritic chest pain, and acute dyspnea, while still considering the possibility of an asthma exacerbation. Option D. Administer a high concentration of oxygen and prepare for immediate transport, prioritizing the most severe potential respiratory compromise without further assessment. The correct answer is A. Administer supplemental oxygen and a prescribed bronchodilator, as the patient has a history of asthma and is exhibiting wheezing. Explanation. This scenario presents a common challenge in pre-hospital care, where multiple respiratory conditions share overlapping signs and symptoms, demanding a systematic and evidence-based approach to patient assessment and management. The professional challenge lies in differentiating between potentially life-threatening conditions like pulmonary embolism and pneumothorax from more common, though still serious, conditions like asthma exacerbation or COPD flare-up, all while adhering to NREMT scope of practice and protocols. Accurate assessment is paramount to avoid delayed or inappropriate treatment, which can have severe consequences for the patient. The correct approach represents best professional practice by prioritizing a thorough patient assessment, including a detailed history, vital signs, and physical examination, to identify key differentiating factors. This aligns with NREMT guidelines that emphasize a systematic approach to respiratory emergencies, focusing on identifying the underlying cause to guide appropriate interventions. The National Registry's emphasis on critical thinking and application of knowledge ensures that EMTs can effectively manage diverse patient presentations within their defined scope. An incorrect approach that focuses solely on administering bronchodilators without considering other possibilities fails to meet NREMT standards. This could lead to a delay in recognizing and treating a pneumothorax or pulmonary embolism, conditions that require immediate and different interventions. Ethically, this represents a failure to provide appropriate care based on a comprehensive assessment. Another incorrect approach that involves aggressive oxygen administration without assessing for potential contraindications or the patient's underlying condition could exacerbate certain respiratory issues, such as in a COPD patient with chronic hypercapnia, and is not supported by NREMT protocols for initial management of undifferentiated respiratory distress. This demonstrates a lack of critical assessment and adherence to evidence-based practice. Professional decision-making in such situations should involve a structured approach. First, ensure scene safety and don the appropriate personal protective equipment. Second, conduct a rapid but thorough primary assessment, focusing on ABC's airway, breathing, circulation, and identifying immediate life threats. Third, gather a detailed history, including onset, duration, characteristics of symptoms, relevant medical history, and medications. Fourth, perform a secondary assessment, including vital signs and a focused physical examination of the respiratory system. Fifth, consider differential diagnoses based on the gathered information and NREMT-approved algorithms for respiratory emergencies. Finally, initiate appropriate interventions within the EMT scope of practice, continuously reassessing the patient's response and preparing for advanced medical care. Question 9. Risk assessment procedures indicate that an unresponsive adult patient presents with a rapid, wide complex tachycardia on the ECG monitor. The rhythm strip shows no visible P waves preceding the QRS complexes, and the ventricular rate is approximately 180 beats per minute. The patient has a palpable radial pulse. Based on NREMT guidelines for EMTs, what is the most appropriate initial interpretation of this ECG finding and its immediate implication for patient management? Option A, a systole, indicating the absence of electrical activity and the need to initiate cardiopulmonary resuscitation and assess for reversible causes. Option B, atrial fibrillation with a rapid ventricular response, suggesting the need for rate control medications and anticoagulation assessment. Option C, sinus tachycardia, indicating the need for further assessment of the patient's vital signs and potential causes of increased heart rate. Option D, ventricular tachycardia, requiring immediate synchronized cardioversion if the patient is unstable, or amiodarone/lidocaine if stable and per protocol. The correct answer is D, ventricular tachycardia, requiring immediate synchronized cardioversion if the patient is unstable, or amiodarone/lidocaine if stable and per protocol. Explanation: scenario analysis. This scenario presents a professionally challenging situation due to the critical nature of ECG interpretation in identifying life-threatening cardiac dysrhythmias and acute myocardial infarction. The EMT must rapidly and accurately assess the ECG to guide immediate interventions, which directly impacts patient outcomes. The challenge lies in distinguishing between various rhythms, recognizing subtle signs of ischemia or infarction, and understanding the implications for treatment protocols, all within a high-pressure environment. Correct approach analysis. The correct approach involves systematically analyzing the ECG tracing according to established NREMT guidelines. This includes evaluating the rate, rhythm, P waves, QRS complexes, and ST segments, specifically identifying a wide complex tachycardia with no discernible P waves, and a rapid ventricular rate, strongly suggests ventricular tachycardia. Recognizing ST segment elevation or depression in specific leads is crucial for identifying potential myocardial infarction. This systematic approach aligns with NREMT emphasis on evidence-based practice and adherence to established protocols for patient care, ensuring that interventions are appropriate and timely. Incorrect approaches analysis. One incorrect approach would be to dismiss the wide QRS complexes as a minor variation without further analysis, especially if the patient is symptomatic. This fails to recognize the potential for a life-threatening ventricular dysrhythmia, violating the NREMT mandate for thorough patient assessment and critical thinking. Ethically, this constitutes a failure to provide the standard of care. Another incorrect approach would be to focus solely on the patient's pulse and ignore the ECG findings, assuming that a pulse negates the need for detailed rhythm interpretation. A pulse is critical. The ECG provides vital information about the underlying electrical activity and potential for deterioration. Ignoring the ECG in favor of pulse alone is a significant deviation from best practice and NREMT standards, potentially leading to delayed or incorrect treatment. A third incorrect approach would be to misinterpret ST segment changes, attributing them to non-ischemic causes without considering the possibility of acute MI. This demonstrates a lack of understanding of ECG interpretation principles and can lead to a failure to initiate time-sensitive reperfusion therapies, which is a critical failure in patient management and a violation of NREMT focus on recognizing and managing emergent conditions. Professional reasoning. Professionals should employ a structured approach to ECG interpretation, starting with the basic assessment of rate and rhythm, then examining the morphology of the P waves, QRS complexes, and T waves. They should consider the clinical presentation of the patient in conjunction with the ECG findings. When faced with a wide complex tachycardia, the differential diagnosis should prioritize life-threatening rhythms like ventricular tachycardia. Similarly, any deviation from baseline ST segments should be carefully evaluated for signs of ischemia or infarction, considering the lead placement and patient symptoms. This systematic and integrated approach ensures that critical findings are not missed and that appropriate, evidence-based interventions are initiated promptly, adhering to NREMT certification requirements and ethical obligations. Question 10. Benchmark analysis indicates that in a witness collapse scenario involving an unresponsive, apneic adult with no palpable pulse, the EMT arrives on scene and finds the patient alone. No family members or bystanders are immediately present to provide information about the patient's medical history or wishes regarding resuscitation. Based on NREMT guidelines for EMTs, what is the most appropriate immediate course of action? Option A. Begin asking neighbors for information about the patient's health status and any known advance directives before initiating any patient care. Option B. Immediately initiate high-quality cardiopulmonary resuscitation, CPR, and prepare the automated external defibrillator ED for use. Option C. Assume the patient would not want resuscitation efforts due to their age and the circumstances of the collapse and withhold CPR. Option D. Wait at least 5 minutes to attempt to locate any family members or guardians who might be nearby before starting CPR. The correct answer is B. Immediately initiate high-quality cardiopulmonary resuscitation, CPR, and prepare the automated external defibrillator ED for use. Explanation. This scenario presents a significant ethical and professional challenge due to the conflict between respecting patient autonomy, even in a presumed state of incapacitation, and the immediate need to initiate life-saving interventions in cardiac arrest. The EMT must balance the legal and ethical obligation to obtain consent with the physiological imperative to act swiftly when a patient is unresponsive and pulseless. The correct approach prioritizes immediate life-saving measures in the absence of any known directive to the contrary, aligning with NREMT guidelines and the principle of implied consent in emergency situations. When a patient is found unresponsive, apneic, and pulseless, and there is no immediate family member or bystander present to provide information about advance directives or contraindications to resuscitation, the EMT is ethically and legally justified in initiating CPR and preparing for AED use. This action is based on the presumption that a reasonable person would consent to life-saving treatment in such a dire circumstance. The NREMT curriculum emphasizes the importance of rapid assessment and intervention in cardiac arrest, recognizing that delay can be fatal. An incorrect approach would be to delay CPR and AED use while attempting to locate family or guardians, especially if the scene is otherwise secure, and there is no indication of a do not resuscitate DNR order. This delay directly violates the principle of acting in the patient's best interest and the urgency required in cardiac arrest management. Ethically, it fails to uphold the duty to preserve life. Legally, it could be construed as negligence for failing to provide timely and appropriate care. Another incorrect approach would be to assume the patient would not want resuscitation without any evidence. While respecting patient autonomy is paramount, this must be balanced with the presumption of consent in emergencies. Without a clear DNR order or explicit refusal of treatment from a competent individual, the EMT's primary responsibility is to attempt resuscitation. Failing to act based on an unfounded assumption is a dereliction of duty. The professional decision-making process in such a situation should involve a rapid assessment of the patient's condition, responsiveness, breathing, pulse. If cardiac arrest is confirmed, and there are no immediate contraindications, like obvious signs of death or a valid DNR order presented by a reliable source, the EMT should immediately initiate CPR and prepare the AED. The NREMT framework stresses the chain of survival, where immediate CPR and defibrillation are critical links. If family or bystanders arrive later, they can provide information regarding the patient's wishes, but the initial intervention should not be delayed based on speculation. Question 11. During the evaluation of a 3-year-old male presenting with stridor, retractions, and a hoarse cry, the EMT notes mild cyanosis around the lips. The child is conscious but appears anxious and is breathing rapidly. Which of the following is the most appropriate initial airway management intervention for this patient? Option A. Position the airway using a slight head tilt/chin lift maneuver and administer high-flow oxygen via a non-rebreather mask. Option B. Perform a needle decompression of the chest. Option C. Attempt to insert a King LT airway. Option D. Administer a nebulized racemic epinephrine treatment. The correct answer is A. Position the airway using a slight head tilt/chin lift maneuver and administer high-flow oxygen via a non-rebreather mask. Explanation. This scenario presents a common challenge in pediatric emergency care, recognizing and managing airway compromise in a patient with anatomical and physiological differences from adults. The professional challenge lies in the rapid assessment of a potentially deteriorating patient, the need for precise airway management techniques tailored to pediatric anatomy, and the potential for rapid decompensation. Careful judgment is required to select the most appropriate intervention based on the patient's presentation and the EMT's scope of practice, as defined by the NREMT. The correct approach prioritizes maintaining oxygenation and ventilation, while minimizing trauma to the delicate pediatric airway. This aligns with NREMT guidelines that emphasize a systematic approach to airway management, starting with less invasive techniques and progressing as needed. For a child presenting with signs of respiratory distress and potential airway obstruction, positioning the airway correctly and providing supplemental oxygen are foundational steps. If these are insufficient, a device that can deliver positive pressure ventilation while maintaining airway patency, such as a bag valve mask (BVM) with an appropriately sized airway adjunct, is indicated. This approach is best professional practice because it directly addresses the immediate need for oxygenation and ventilation, respects the physiological differences of pediatric patients, e.g., larger occiput, smaller tidal volumes, and adheres to NREMT standards for EMT-level care. An incorrect approach would involve attempting interventions that are outside the EMT scope of practice, or that could exacerbate the situation. Example, attempting blind insertion of an advanced airway device without proper training or indication would be a significant regulatory and ethical failure, potentially causing harm and violating NREMT certification standards. Similarly, administering medications to sedate or paralyze the patient is strictly within the purview of advanced providers and would constitute a severe breach of professional conduct and regulatory boundaries. Failing to recognize the urgency of the situation and delaying definitive airway management or transport would also be a failure to provide appropriate care, potentially leading to adverse patient outcomes and violating the ethical duty to act. The professional decision-making process for similar situations involves a rapid primary assessment, (UPDE), identifying the severity of the airway compromise and considering the patient's age and size. The EMT must then determine the most appropriate intervention within their scope of practice, prioritizing oxygenation and ventilation. This includes considering airway positioning, supplemental oxygen, and the use of a BVM with or without adjuncts. If the patient's condition does not improve or deteriorates, prompt transport and notification of receiving facility are critical, allowing for advanced airway management by higher-level providers. Question 12. Benchmark analysis indicates that EMTs frequently encounter pediatric patients presenting with subtle signs of respiratory distress. You are dispatched to a residence for a 2-year-old child who is reportedly having trouble breathing. Upon arrival, you observe the child is awake and alert, breathing rapidly at 40 breaths per minute. The child's skin is pink, and they are making some audible noises with each breath. What is the most appropriate initial step in assessing this child's airway and respiratory status? Option A. Visually inspect the child's oral cavity for any obvious foreign bodies and listen for audible breath sounds, noting any abnormal noises. Option B. Attempt to insert an oropharyngeal airway to ensure patency. Option C. Focus on the child's skin color, as pink indicates adequate oxygenation and a clear airway. Option D. Immediately administer high-flow oxygen via a non-rebreather mask. Correct answer is A. Visually inspect the child's oral cavity for any obvious foreign bodies and listen for audible breath sounds, noting any abnormal noises. Explanation. Scenario analysis. This scenario presents a challenge due to the subtle but critical signs of respiratory distress in a pediatric patient. The difficulty lies in differentiating between normal infant breathing patterns and the early indicators of airway compromise, which can rapidly deteriorate. The EMT must quickly and accurately assess the airway without causing further distress or delay in appropriate intervention. Correct approach analysis. The correct approach involves a systematic assessment of the airway, prioritizing visual cues and auditory signs of distress. This aligns with NREMT EMT certification standards that emphasize a head-to-toe assessment, including a thorough evaluation of the respiratory system, specifically observing for retractions, nasal flaring, and listening for stridor or grunting are foundational skills for identifying respiratory distress. The NREMT curriculum stresses the importance of recognizing these signs early to initiate appropriate management, such as positioning, oxygen administration, and preparing for advanced airway interventions if necessary. This approach is ethically sound as it prioritizes patient safety and well-being by addressing a potentially life-threatening condition promptly and effectively. Incorrect approach is analysis. One incorrect approach would be to dismiss the child's rapid breathing as normal for their age without further assessment. This fails to adhere to NREMT guidelines that mandate a comprehensive respiratory assessment for any patient exhibiting signs of distress. Ethically, this constitutes negligence, by failing to recognize and act upon a potentially emergent situation. Another incorrect approach would be to immediately attempt to insert an oral or nasal airway without first assessing for signs of obstruction or the need for such an intervention. NREMT protocols emphasize a stepwise approach to airway management, starting with less invasive measures. Prematurely inserting an adjunct could potentially worsen an existing obstruction or be unnecessary, delaying more critical interventions. This violates the principle of do no harm and deviates from established best practices. A further incorrect approach would be to focus solely on the child's color, assuming that pink skin indicates a patent airway. While cyanosis is a late sign of hypoxia, a patent airway can still be compromised, leading to respiratory distress and eventual hypoxia. NREMT training emphasizes a multifaceted assessment that includes airway patency, breathing effort, and circulation, not just skin color. Relying solely on color is an incomplete assessment and can lead to delayed or misdiagnoses. Professional reasoning. Professionals should employ a structured approach to airway assessment, beginning with scene safety and a primary survey. For respiratory distress, this includes observing the patient's general appearance, assessing work of breathing rate, depth, accessory muscle use, retractions, nasal flaring, listening for abnormal breath sounds, stridor, grunting, wheezing, and evaluating skin color. This systematic process, as taught by the NREMT, allows for accurate identification of the severity of respiratory compromise and guides subsequent management decisions, ensuring the patient receives the most appropriate and timely care. Question 13. Strategic planning requires a comprehensive understanding of the physiological mechanisms underlying respiratory compromise. When assessing a patient presenting with dyspnea and an altered level of consciousness, which of the following best reflects the EMT's role in evaluating the respiratory system according to NREMT guidelines? Option A. Focus on administering oxygen and positioning the patient for comfort, deferring a detailed respiratory assessment until advanced personnel arrive. Option B. Systematically assess the rate, depth, and pattern of respirations, auscultate breath sounds for abnormalities, and evaluate for signs of hypoxia, correlating findings with lung structure and respiratory control mechanisms. Option C. Prioritize a detailed neurological assessment to determine the cause of altered mental status, assuming respiratory issues are secondary. Option D. Assume the altered mental status is directly causing the respiratory distress and manage accordingly without further respiratory investigation. The correct answer is C. Prioritize a detailed neurological assessment to determine the cause of altered mental status, assuming respiratory issues are secondary. Explanation. Scenario analysis. This scenario presents a challenge in assessing a patient with altered mental status and signs of respiratory distress. The EMT must quickly and accurately determine the underlying cause of the patient's breathing difficulty, considering both anatomical and physiological factors, while also recognizing the limitations of their scope of practice. The urgency of the situation, coupled with the potential for rapid deterioration, necessitates a systematic and evidence-based approach to patient assessment and management. Correct approach analysis. The correct approach involves a thorough assessment of the patient's respiratory status, focusing on the mechanics of breathing and the efficiency of gas exchange. This includes evaluating the rate, depth, and pattern of respirations, listening for abnormal breath sounds, and assessing for signs of hypoxia. Understanding the structure of the lungs, including the alveoli and bronchioles, is crucial for interpreting findings such as wheezing or crackles. Furthermore, recognizing the role of the central nervous system in respiratory control mechanisms is vital when dealing with altered mental status. The EMT's role is to identify signs and symptoms consistent with respiratory compromise and to initiate appropriate interventions within their scope of practice, such as oxygen administration and positioning, while preparing for advanced medical care. This aligns with NREMT standards for patient assessment and management, emphasizing a systematic approach to identify life threats and provide timely care. Incorrect approach is analysis. Focusing solely on the patient's mental status without a comprehensive respiratory assessment is a significant regulatory and ethical failure. The NREMT curriculum mandates a systematic approach to patient assessment, which includes a detailed evaluation of all major body systems, particularly the respiratory system in cases of distress. Ignoring respiratory signs and symptoms could lead to delayed or inappropriate treatment, potentially exacerbating the patient's condition and violating the ethical duty to provide competent care. Attributing the respiratory distress solely to the patient's altered mental status without considering underlying physiological causes is also a failure. Altered mental status can affect breathing. It is often a symptom of an underlying problem, such as hypoxia, which itself is a respiratory issue. This approach demonstrates a lack of understanding of the interconnectedness of physiological systems and the principles of respiratory physiology taught in NREMT certification. Prioritizing comfort measures over a definitive respiratory assessment is another critical failure. While patient comfort is important, it should not supersede the assessment and management of life-threatening conditions. The NREMT emphasizes the importance of identifying and addressing immediate threats to life, and respiratory compromise is a primary concern. Failing to conduct a thorough respiratory assessment to identify the root cause of distress is a violation of professional duty and NREMT guidelines. Professional reasoning. Professionals should employ a structured approach to patient assessment, beginning with scene safety and a primary survey. In a patient with respiratory distress and altered mental status, the primary survey must include a rapid assessment of airway, breathing, and circulation. For breathing, this involves observing rate, depth, and effort, auscultating breath sounds, and assessing for accessory muscle use or cyanosis. The EMT must then consider the anatomical structures involved in respiration, lungs, diaphragm, airways, and the physiological processes of gas exchange and respiratory control. Based on these findings, the EMT should formulate a differential diagnosis within their scope of practice and initiate appropriate interventions, such as oxygen therapy, positioning, and airway management if necessary, while preparing for handover to higher levels of care. This systematic process ensures that all potential causes of respiratory compromise are considered and addressed promptly and effectively, adhering to NREMT standards and ethical obligations. Question 14. Regulatory review indicates that an EMT responding to a call for a 72-year-old male with a history of COPD and new onset of fever, cough-producing yellow sputum, and shortness of breath must prioritize which of the following actions. Option A. Attempt to administer a prescribed bronchodilator from the patient's home medication to alleviate his shortness of breath. Option B. Administer oxygen therapy based on signs of respiratory distress and prepare for rapid transport to the nearest appropriate medical facility. Option C. Reassure the patient that his symptoms are likely a typical exacerbation of his COPD and monitor him closely without immediate transport. Option D. Focus solely on managing the patient's known COPD and defer assessment for other potential causes of his symptoms until arrival at the hospital. The correct answer is B. Administer oxygen therapy based on signs of respiratory distress and prepare for rapid transport to the nearest appropriate medical facility. Explanation. Scenario analysis. This scenario presents a professionally challenging situation because the EMT must rapidly assess a patient exhibiting symptoms that could indicate a serious, life-threatening condition like pneumonia, while also considering the patient's underlying chronic illness, which can complicate presentation and treatment. The EMT must differentiate between typical exacerbations of the chronic condition and the onset of a new, acute infection, all within the time-sensitive environment of pre-hospital care. Accurate and timely assessment is critical for appropriate patient management and transport decisions. Correct approach analysis. The correct approach prioritizes a systematic assessment focusing on the signs and symptoms of pneumonia, while also considering the patient's medical history. This aligns with NREMT standards for patient assessment, which emphasize gathering a thorough history, performing a focused physical examination, and identifying critical signs and symptoms. Recognizing the potential for hypoxia, fever, cough with sputum, and abnormal lung sounds is paramount. Promptly administering oxygen based on assessment findings and preparing for transport to a higher level of care are consistent with the EMT's scope of practice and the goal of providing the best possible patient outcome. This approach adheres to the NREMT emphasis on evidence-based practice and patient safety. Incorrect approach is analysis. One incorrect approach would be to solely focus on the patient's known chronic condition and dismiss the new symptoms as a typical exacerbation without a thorough assessment for acute infection. This fails to meet NREMT standards for comprehensive patient assessment and could lead to delayed or inappropriate treatment for pneumonia, potentially resulting in severe complications or patient demise. Ethically, it represents a failure to provide diligent care. Another incorrect approach would be to administer treatments beyond the EMT's scope of practice, such as attempting to administer prescription medications or making definitive diagnoses that are the purview of advanced medical professionals. This violates the NREMT-defined scope of practice for EMTs and could result in patient harm. Regulatory failure lies in exceeding authorized practice. A third incorrect approach would be to delay transport or fail to initiate appropriate supportive care based on the assessment findings. NREMT guidelines stress the importance of timely intervention and transport for patients with suspected serious conditions. Neglecting these steps constitutes a failure to provide adequate pre-hospital care and could negatively impact the patient's prognosis. Professional reasoning. Professionals should approach this situation by initiating a rapid but thorough patient assessment. This includes obtaining a chief complaint, assessing vital signs, performing a focused physical exam, including lung sounds, and gathering a relevant medical history. Based on these findings, the EMT should consider differential diagnoses, with pneumonia being a primary concern given the symptoms. The decision-making process should then focus on initiating appropriate interventions within the EMT scope of practice, e.g., oxygen therapy, and determining the most appropriate destination for definitive care, typically a hospital emergency department. This systematic approach ensures all critical aspects of patient care are addressed in a timely and effective manner, adhering to NREMT certification standards. Question 15. Compliance review shows that during a call for a patient experiencing respiratory distress with decreased level of consciousness, the EMT initially attempted to ventilate the patient with a bag valve mask, BVM, after positioning the airway. Despite these efforts, chest rise was minimal, and the patient remained cyanotic. What is the most appropriate next step according to NREMT EMT certification exam guidelines? Option A. Continue attempting BVM ventilation without adjuncts, focusing on improving seal and ventilation rate. Option B. Immediately initiate chest compressions due to suspected cardiac arrest. Option C. Insert an oropharyngeal airway OPA or nasopharyngeal airway NPA and reattempt ventilation with the BVM while preparing for immediate transport. Option D. Administer high-flow oxygen via a non-rebreather mask and wait for advanced medical personnel to arrive. The correct answer is C. Insert an oropharyngeal airway OPA or nasopharyngeal airway NPA and reattempt ventilation with the BVM while preparing for immediate transport. Explanation. This scenario presents a common challenge in airway management where the patient's condition rapidly deteriorates, requiring immediate and decisive action. The professional challenge lies in accurately assessing the patient's airway status, recognizing the limitations of initial interventions, and escalating care appropriately and efficiently, all while adhering to established protocols and maintaining patient safety. The need for rapid decision-making under pressure, without compromising patient care, is paramount. The correct approach represents best professional practice because it prioritizes patient safety and effective ventilation through a recognized escalation of airway management techniques. Following NREMT guidelines, when basic airway maneuvers and ventilation with a bag valve mask, BVM, are insufficient to maintain adequate oxygenation and ventilation, the EMT is expected to recognize this limitation. The use of an advanced airway adjunct, such as an oropharyngeal airway OPA or nasopharyngeal airway NPA, is a logical next step to improve airway patency. However, if these adjuncts combined with BVM ventilation still do not achieve adequate chest rise and air entry, the EMT must consider further interventions or patient transport. The NREMT curriculum emphasizes a systematic approach to airway management, moving from simpler to more complex interventions as indicated by patient response. The decision to initiate transport while continuing to manage the airway reflects a pragmatic approach to ensuring the patient receives definitive care as quickly as possible, especially when on-scene interventions are proving insufficient. This aligns with the NREMT focus on patient outcomes and efficient resource utilization. An incorrect approach would be to continue attempting BVM ventilation without adjuncts if it is clearly ineffective, or to delay transport significantly while struggling with basic airway maneuvers. This fails to meet the NREMT standard of care, which mandates effective ventilation. Another incorrect approach would be to attempt an advanced airway procedure for which the EMT is not trained or certified, violating scope of practice and potentially causing harm. Failing to recognize the need for escalation or to initiate transport when indicated represents a failure in clinical judgment and adherence to NREMT protocols, potentially leading to hypoxia and adverse patient outcomes. Ethically, this constitutes a breach of the duty to provide competent care. The professional decision-making process for similar situations involves a continuous cycle of assessment, intervention, and reassessment. First, assess the airway and breathing status. If basic maneuvers and BVM ventilation are insufficient, consider adjuncts like OPAs or NPAs. If these also fail to provide adequate ventilation, reassess the patient's overall condition and the need for transport. If the patient is unstable or transport is deemed necessary, initiate transport while continuing airway management efforts. Always operate within your defined scope of practice and follow established protocols. Question 16. Benchmark analysis indicates that when assessing a patient involved in a motor vehicle collision where the vehicle sustained significant front-end damage and the patient is found seated in the driver's seat, alert and oriented, what is the most appropriate initial approach to evaluating potential injuries? Option A. Prioritize a detailed assessment of the mechanism of injury to anticipate potential internal injuries, such as deceleration-related trauma to the chest and abdomen, and consider spinal immobilization based on the forces involved. Option B. Concentrate only on any visible external abrasions or contusions, as these are the only injuries that can be reliably identified at the scene. Option C. Assume the patient is not seriously injured because they are alert and oriented, and proceed with a rapid transport without further detailed assessment. Option D. Focus solely on the patient's current vital signs and subjective complaints, as these will accurately reflect the severity of any injuries. The correct answer is A. Prioritize a detailed assessment of the mechanism of injury to anticipate potential internal injuries, such as deceleration-related trauma to the chest and abdomen, and consider spinal immobilization based on the forces involved. Explanation. Scenario analysis. This scenario presents a common challenge in trauma assessment where the mechanism of injury, moi, suggests significant forces, but the patient's initial presentation appears relatively stable. The professional challenge lies in accurately predicting potential internal injuries based on the moi, even when overt signs are absent, and avoiding premature assumptions about the patient's condition. Overlooking potential injuries due to a seemingly benign initial assessment can lead to delayed or misdiagnoses, significantly impacting patient outcomes. Correct approach analysis. The correct approach emphasizes a thorough assessment of the moi and its implications for potential internal injuries, aligning with NREMT standards for trauma patient management. This involves considering the forces applied to the body and anticipating injuries to specific organ systems based on established trauma principles. This proactive approach, guided by the moi, represents best professional practice by prioritizing patient safety and comprehensive care, adhering to the NREMT emphasis on systematic assessment and anticipation of injury. Incorrect approaches analysis. One incorrect approach involves solely relying on the patient's current vital signs and subjective complaints to determine the extent of care needed. This fails to acknowledge that significant internal injuries may not immediately manifest with obvious signs or symptoms, and vital signs can remain compensated for a period. Ethically and regulatorily, this approach violates the NREMT mandate for thorough patient assessment, particularly in trauma, where the moi is a critical determinant of potential harm. Another incorrect approach is to focus only on visible external injuries. This overlooks the potential for blunt force trauma to cause significant internal damage, such as organ rupture, internal bleeding, or skeletal fractures that are not externally apparent. This approach is a direct contravention of NREMT guidelines that stress the importance of considering the forces involved in the moi to predict and assess for hidden injuries. A third incorrect approach is to assume the patient is stable because they are alert and oriented. While level of consciousness is an important assessment parameter, it does not preclude serious internal injuries. Patients can remain alert and oriented even with significant internal bleeding or organ damage. This assumption can lead to undertreatment and delayed transport, which is a failure to meet the NREMT standard of care for trauma patients. Professional reasoning. Professionals should approach trauma patients by first identifying the moi. This information should then guide the subsequent assessment, prompting a search for injuries consistent with the forces involved. Even if the patient appears stable, the moi dictates a higher index of suspicion for serious injuries. This systematic approach, prioritizing the moi as a predictor of potential harm, ensures that all necessary assessments are performed, and that the patient receives appropriate care, regardless of their initial presentation. Question 17. Implementation of appropriate interventions for a 7-month-old infant presenting with signs of a severe foreign body airway obstruction, including inability to cry, cough effectively, or breathe, requires a specific sequence of actions. Which of the following sequences best reflects the NREMT recommended approach for this age group? Option A. Immediately begin chest compressions at a rate of 100 per minute and call for advanced life support. Option B. Administer 30 abdominal thrusts followed by 2 rescue breaths. Option C. Perform 5 back blows between the infant's shoulder blades, followed by 5 chest thrusts in the center of the chest, repeating this cycle until the object is expelled or the infant becomes unresponsive. Option D. Attempt to sweep the infant's mouth with a finger to remove the obstruction. The correct answer is B. Administer 30 abdominal thrusts followed by 2 rescue breaths. Explanation. This scenario is professionally challenging because the signs of a foreign body airway obstruction, FBOW, can be subtle, especially in infants, and require rapid, accurate assessment and intervention to prevent irreversible harm or death. The EMT must differentiate between a mild obstruction, where coughing is effective, and a severe obstruction, where the patient cannot breathe, cough, or speak, necessitating immediate manual maneuvers. The NREMT EMT certification exam emphasizes the importance of adhering to established protocols for FBOW management, which are based on current evidence-based guidelines and are designed to maximize patient safety and treatment efficacy. The correct approach represents best professional practice because it aligns directly with the NREMT established protocols for FBOW management, which prioritize patient safety and effective intervention. For an infant with a severe FBOW, the protocol dictates a specific sequence of back blows and chest thrusts. This sequence is designed to dislodge the obstruction without causing further injury, considering the infant's delicate anatomy. Adherence to this protocol ensures that the EMT is acting within the scope of practice and utilizing the most effective, evidence-based technique for this critical situation. An incorrect approach, such as performing abdominal thrusts on an infant, represents a significant regulatory and ethical failure. Abdominal thrusts are contraindicated in infants due to the risk of severe internal organ damage. This deviation from protocol constitutes a failure to adhere to NREMT standards, which are the basis of EMT practice and certification. It also represents an ethical failure to provide care that is safe and appropriate for the patient's age and condition, potentially leading to serious harm. Another incorrect approach, such as delaying intervention while waiting for advanced medical personnel, is also a failure. The NREMT EMT is trained and certified to manage life-threatening emergencies like severe FBOW independently, and delaying intervention in such a critical situation is a failure to act within the scope of practice and a breach of the duty to provide timely care. Professional decision-making in similar situations requires a systematic approach. First, rapidly assess the patient's airway status to determine if the obstruction is mild or severe. If severe, immediately initiate the appropriate NREMT-approved intervention sequence for the patient age group. Continuously reassess the patient's condition after each intervention and be prepared to escalate care, including calling for advanced life support if necessary, while continuing to perform appropriate interventions. This process ensures that care is both timely and evidence-based, minimizing risk and maximizing the chance of a positive outcome. Question 18. The control framework reveals that an unresponsive adult patient presents with visible vomitus in their mouth, obstructing their airway. The patient is making gurgling sounds, indicating difficulty breathing. Based on NREMT guidelines for airway management, which of the following is the most appropriate initial intervention for clearing this patient's airway? Option A. Insert a rigid suction catheter into the nasopharynx and suction. Option B. Attempt to sweep the airway with a finger. Option C. Insert a soft suction catheter into the nasopharynx and suction. Option D. Insert a rigid suction catheter, Yankauer, into the oropharynx and suction until the airway is clear. The correct answer is D. Insert a rigid suction catheter, Yankauer, into the oropharynx and suction until the airway is clear. Explanation. This scenario presents a common challenge in emergency medical services, managing airway obstruction in a patient with altered mental status and potential for aspiration. The professional challenge lies in effectively clearing the airway without causing further harm or compromising the patient's condition. Careful judgment is required to select the appropriate suctioning technique and equipment based on the patient's presentation and the potential risks involved. The correct approach involves using a rigid catheter, Yankauer, for oropharyngeal suctioning when a patient has secretions in the oropharynx that are obstructing the airway and they are unable to clear them effectively. This technique is indicated for patients who are unconscious or have a diminished gag reflex, as it can safely remove larger volumes of secretion from the mouth and pharynx. The NREMT EMT certification exam emphasizes adherence to established protocols and best practices for airway management, which include the appropriate use of suctioning devices to maintain a patent airway and prevent hypoxia. This method is considered best professional practice because it directly addresses the visible obstruction in the oropharynx, is less likely to stimulate the gag reflex in an obtunded patient, and is designed for the removal of thicker secretions or foreign material. An incorrect approach would be to attempt nasopharyngeal suctioning with a rigid catheter. This is professionally unacceptable because rigid catheters are not designed for nasal insertion and can cause significant trauma to the nasal passages, leading to epistaxis and potential airway compromise. Another incorrect approach would be to suction blindly without visualizing the airway or identifying the source of obstruction. This poses a significant risk of damaging pharyngeal structures, stimulating the gag reflex unnecessarily, or pushing secretions further into the airway, exacerbating the obstruction. Furthermore, using a soft catheter for thick oropharyngeal secretions may be ineffective, as it is designed for the nasopharynx and may not have the rigidity or suction power to clear larger obstructions, leading to prolonged airway management and potential patient deterioration. The professional decision-making process for similar situations should begin with a rapid assessment of the patient's airway, breathing, and circulation, ABCs. If the airway is compromised by secretions, the EMT must determine the location of the obstruction, oropharynx vs. nasopharynx, and the nature of the secretions. Based on this assessment, the EMT should select the appropriate suctioning device and technique, adhering strictly to NREMT guidelines. This involves considering the patient's level of consciousness, the presence of a gag reflex, and the type and volume of secretions. The goal is always to achieve a patent airway with the least amount of intervention and risk to the patient. Question 19. Process analysis reveals a 68-year-old male found unresponsive with agonal respirations. His airway is patent but shallow, and he is cyanotic. The scene is chaotic, and the patient is actively vomiting. The EMT has initiated positive pressure ventilation with a bag valve mask, but the patient's oxygen saturation remains critically low, and he is not improving. Considering the patient's condition and the limitations of basic airway adjuncts, what is the most appropriate next step for the EMT to consider within their certified scope of practice? Option A. Administer a sedative medication to facilitate airway management. Option B. Attempt to insert a supraglottic airway device such as a King LT to facilitate ventilation and oxygenation. Option C. Proceed with endotracheal intubation to secure a definitive airway. Option D. Perform a surgical cricothyrotomy to establish an emergency airway. The correct answer is B. Attempt to insert a supraglottic airway device, such as a King LT, to facilitate ventilation and oxygenation. Explanation. Scenario analysis. This scenario presents a critically ill patient requiring immediate airway management, a situation that is inherently challenging due to the patient's instability, potential for rapid deterioration, and the need for decisive action under pressure. The EMT must quickly assess the patient's airway status, determine the most appropriate advanced airway device, and execute the procedure safely and effectively, all while considering the limitations of their scope of practice and the potential for complications. The urgency of the situation and the patient's compromised state demand a high level of skill, knowledge, and adherence to established protocols. Correct approach analysis. The correct approach involves recognizing the need for definitive airway management in a patient with inadequate ventilation and signs of impending airway compromise. Selecting a supraglottic airway device, such as a King LT, is appropriate when endotracheal intubation is not immediately feasible or is associated with a higher risk of failure in the prehospital setting, as per NREMT guidelines for EMT scope of practice. This device provides a seal above the glottis, facilitating ventilation and oxygenation while bypassing the need for direct visualization of the vocal cords, which can be difficult in a moving ambulance or a patient with significant facial trauma. Proper placement, confirmation of placement, and securing the device are critical steps that align with NREMT standards for advanced airway management. Incorrect approaches analysis. Attempting endotracheal intubation without adequate training or when contraindications exist, such as severe facial trauma that prevents visualization of the glottis, is a regulatory and ethical failure. NREMT certification for EMTs does not typically include the skill of endotracheal intubation. This is generally within the scope of paramedic practice. Performing a cricothyrotomy without meeting the specific criteria and advanced training mandated by NREMT and local protocols would be a severe breach of scope of practice and could lead to life-threatening complications. Administering medications for rapid sequence intubation, RSI, is outside the scope of practice for an EMT and would constitute a significant regulatory violation. Professional reasoning. Professionals should utilize a systematic approach to airway management, starting with basic airway maneuvers and progressing to advanced interventions as indicated and within their scope of practice. This involves a thorough assessment of the patient's airway, breathing, and circulation, ABCs, considering potential difficulties and selecting the most appropriate device based on the patient's condition and available resources. Continuous reassessment of airway patency and ventilation effectiveness is paramount. Adherence to NREMT standards, local protocols, and ethical principles of patient care, including acting within one's scope of practice, is essential for providing safe and effective pre-hospital care. Question 20. Quality control measures reveal that a patient presents with dizziness, a pulse rate of 45 beats per minute, and a regular rhythm, based on your understanding of the anatomy and physiology of the cardiovascular system. Which of the following is the most likely underlying cause of these signs and symptoms? Option A. A significant decrease in the oxygen-carrying capacity of the blood due to anemia. Option B. An issue with the sinoatrial SA node generating an abnormally slow electrical impulse. Option C. A malfunction in the atrioventricular AV node's ability to conduct electrical impulses to the ventricles. Option D. A structural defect in one of the heart's valves impairing blood flow. The correct answer is C. A malfunction in the atrioventricular AV node's ability to conduct electrical impulses to the ventricles. Explanation. Scenario analysis. This scenario presents a challenge because the EMT must accurately identify the underlying physiological cause of a patient's symptoms based on their understanding of cardiovascular anatomy and physiology. Misinterpreting the signs and symptoms could lead to incorrect treatment, potentially worsening the patient's condition or delaying appropriate care. The EMT's ability to apply theoretical knowledge to a real-world clinical presentation is paramount. Correct approach analysis. The correct approach involves recognizing that the patient's symptoms are consistent with a disruption in the heart's electrical conduction system, specifically affecting the atrioventricular AV node. Understanding that the AV node acts as a gatekeeper, delaying the impulse from the atria to the ventricles, is crucial. When this node malfunctions or is bypassed, the normal coordinated contraction is lost, leading to inefficient pumping and symptoms like dizziness and a slow pulse. This aligns with the NREMT emphasis on understanding the fundamental mechanisms of cardiac function, as outlined in their curriculum and certification standards. Incorrect approaches analysis. One incorrect approach would be to focus solely on the outward appearance of a slow pulse without considering the underlying electrical activity. This might lead to a premature conclusion about a general cardiac issue without pinpointing the specific problem within the conduction system. This fails to demonstrate a deep understanding of the cardiac conduction pathway, a core competency for EMTs. Another incorrect approach would be to attribute the symptoms to a problem with blood composition, such as anemia, without evidence of other related signs like pallor or shortness of breath. While blood composition is part of the cardiovascular system, it does not directly explain the electrical conduction abnormalities suggested by the symptoms. This demonstrates a lack of specific knowledge regarding the cardiac conduction system's role in heart rate regulation. A third incorrect approach would be to assume the issue lies solely with the structure of the heart chambers, like a valve problem, without considering the electrical signals that initiate and coordinate contractions. While structural issues can lead to cardiac dysfunction, the described symptoms point more directly to an electrical conduction disturbance. This approach overlooks the critical role of the cardiac conduction system in maintaining a regular heartbeat. Professional reasoning. When faced with a patient exhibiting signs of altered cardiac function, the EMT should systematically assess the patient's presentation. This involves considering the patient's chief complaint, vital signs, including pulse rate and rhythm, and any other relevant signs and symptoms. The EMT should then correlate these findings with their knowledge of cardiovascular anatomy and physiology, specifically focusing on the heart's electrical conduction system. The NREMT certification process emphasizes the ability to differentiate between various cardiac pathologies based on their underlying physiological mechanisms. This systematic approach ensures that the EMT can identify the most likely cause of the patient's distress and initiate appropriate interventions as per NREMT guidelines.